Hello everyone, and welcome to another chapter of Advanced Pathophysiology. Today we jump into chapter 38, the structure and function of the renal and urologic system. As always, my pages may not line up perfectly with those that you're familiar with, but I do believe that we will be reading the entirety of the chapter. It's relatively short. So without much, ado, we'll jump right into it. So the primary function of the kidney is to maintain a stable internal environment for optimal cell and tissue metabolism. The kidneys accomplish these life-sustaining tasks by balancing solute and water transport, excreting metabolic waste products, conserving nutrients, and regulating acids and bases. The kidneys also has an endocrine function, secreting the hormone renin, erythropoietin, and a 1,2,5 dihydroxy vitamin D3 for the regulation of blood pressure, erythrocyte production, and calcium metabolism, respectively. The kidney also can synthesize glucose from amino acids, performing the process of gluconeogenesis. The formation of urine is achieved through the process of the glomerular filtration, tubular reabsorption, and secretion within the kidney. The bladder stores the urine that it receives from the kidney by the way of the ureters. Urine is then removed from the body through the urethra. So, what is new about the kidney and glucose regulation? The human kidney contributes to the regulation of glucose concentration by making glucose through gluconeogenesis. By taking up glucose from the circulation and reabsorbing glucose from the glomerular filtrate, the human liver and kidneys release approximately equal amounts of glucose through gluconeogenesis in a post-absorptive state, so 4 to 12 hours after a meal. Other tissues lack the enzyme necessary for gluconeogenesis, that glucose 6 phosphatase, and cannot participate in gluconeogenesis. In the postprandial state, up to 4 hours after a meal, although overall endogenous glucose release decreased substantially, renal gluconeogenesis accounts for 40% of glucose formed by gluconeogenesis. So about 180 grams of glucose are normally filtered each day by the kidneys. Almost all of this is actively reabsorbed by the means of the sodium glucose cotransporter 2, the SGLT2, a transmembrane protein expressed in the luminal border of the proximal tubule. This ensures sufficient energy is available during fasting periods. When plasma glucose concentrations exceed a threshold, the SGLT2 becomes saturated with glucose, appears in the urine. Individuals with diabetes have an increased transport for glucose from enhanced expression of the SGLT2, and this contributes to hyperglycemia when there is poor glucose control. SGLT2 inhibitors are used for reducing hyperglycemia associated with diabetes. Renal glucose release is stimulated by the epinephrine and is inhibited by insulin. Insulin suppresses glucose release in both the liver and the kidneys. The kidneys do not synthesize glycogen and therefore do not release glucose through the glycogenolysis. In the post-absorptive state, the kidneys utilize about 10% of all glucose used up by the body. When there is hypoglycemia, the liver initially releases glucose through glycogenolysis and then increases gluconeogenesis. The kidneys also counter-regulate hypoglycemia through gluconeogenesis, which may explain in part why individuals with renal failure tend to develop hypoglycemia. So, what is the structure of the renal system? Structures of the kidneys. The kidneys are paired organs located in the posterior region of the abdomen cavity behind the peritoneum. They lay on either side of the vertebral column, with their upper and lower poles extending from approximately the 12th thoracic to the 3rd lumbar vertebra. The right kidney is slightly lower than the left and is displaced downward by the overlying liver. Each kidney is approximately 10 centimeters long, 5 to 6 centimeters wide, and 3 to 4 centimeters thick. A tightly adherent capsule, the renal capsule, surrounds each kidney, and the kidney then is embedded in a mass of fat. The capsule and fatty layer are covered with a double layer of renal fascia, composed of fibrous tissue that attaches the kidney to the posterior abdominal wall. So here, if we're looking at the adrenal gland, the liver, the 12th rib, the right kidney, the ureter, and urinary bladder. Then on the other side, we're taking a look at the spleen, the renal artery, the renal vein, the left kidney, the abdominal aorta, the inferior vena cava, the common iliac artery and vein, and finally, again, the urethra. The cushion of fat and the position of the kidney between the abdominal organs and the muscles of the back protect it from trauma. The hilum is a medial indentation in the kidney and is located of the entry and exit for the renal blood vessels. The nerves, the lymphatic vessels, and ureter. The structures of the kidney are summarized in the figure 38.2. The outer layer of the kidney is called the cortex and contains all of the glomeruli, most of the proximal tubules, and some segments of the distal tubule. The medulla forms the inner part of the kidney and consists of a region called the pyramids. Renal columns are an extension of the cortex and lie between the pyramids and the extend to the renal pelvis. The apex of the pyramids project into minor calyces, or cup-shaped cavities that unite to form major calyces. The minor calyces receive urine from the collecting ducts through the renal papilla. The major calyces join to form the renal pelvis, which connects with the proximal end of the ureter. The walls of the calyces, pelvis, and ureter are lined with epithelial cells and contain smooth muscle cells that contract to move urine to the bladder. The structural unit of the kidney is a lobe. Each lobe is composed of a pyramid and overlying cortex. On average, there are 14 lobes in each kidney. So we're looking at the structure here of the kidney. It looks like we got the medulla, the cortex, the renal pyramids, the papilla, the major cortex, the major calyx, then the minor calyces, the renal capsule and the renal columns. And then it looks like on the other side we've got that whole renal hilum, the renal artery and vein, the renal pelvis, and finally the ureter. That brings us down to the nephron. The nephron is a functional unit of the kidney. Each kidney contains about 1.2 million nephrons. The nephron is a tubular structure with subunits that include the renal corpuscle, proximal convoluted tubule, loop of Henle, also known as nephron ansa, and distal convoluted tubule and collecting ducts, all of which contribute to the formation of urine. The different epithelial cells lining various segments of the tubule facilitate the special functions of reabsorption and secretion. So here we got the components of the nephron. I'll leave that up for just a moment so you can take a look at that. And actually, while we're at it, let's make it a little bigger. There we go. So here we're taking a look at the epithelial cells of the various segments of nephron tubules. The brush border and high number of mitochondria in the cells of the proximal convoluted tubule permit reabsorption of 60% of the glomerular filtrate. The intercalated, the blue text, secrete either hydrogen or bicarb and reabsorb potassium. The principal, the magenta text, reabsorbs sodium and water and secrete potassium. So the kidney has three kinds of nephrons. The superficial cortical nephron, which is about 85%, which extends partially into the medulla. The mid-cortical nephron, with short or long loops. And the juxtamedullary nephron, which lie close to and extend deep into the medulla and are important for the concentration of urine. The glomerulus is a tuft of capillaries that loop into the circular Bowman capsule, like fingers pushed into bread dough. The Bowman capsule is composed of the visceral epithelium, that visceral layer, forming podocytes. The visceral epithelium is reflected back at the vascular pole to become the outer parietal epithelium, or parietal layer. The mesangial cells, they're shaped like smooth muscle cells, and the mesangial matrix, a type of connective tissue secreted by mesangial cells, lie between and support the glomerular capillaries. Different mesangial cells contract like smooth muscle cells to regulate glomerular capillary blood flow. They also have phagocytic properties similar to monocytes and release inflammatory cytokines and growth factor. Together, the glomerulus, Bowman capsule, and mesangial cells are called the renal corpuscle. So here we're taking a look at the nephron unit with its blood vessels. Blood flows through nephron vessels as follows: the interlobular artery, efferent arterial glomerulus, the efferent arteriole, the pertubular capillaries, the venules, the interlobar vein. And here we get another picture, the anatomy of the glomerulus and juxtaglomerular apparatus. A longitudinal cross-section of glomerulus and juxtaglomerular apparatus. And then picture B, the longitudinal cross-section illustrates detail of the glomerular structure. So, the glomerular filtration membrane filters blood components through its three layers: an inner capillary endothelium, a middle glomerular basement membrane, and an outer layer, the visceral epithelium, which forms the inner layer of the Bowman capsule. The capillary endothelium is composed of cells in continuous contact with the basement membrane and contains pores. The pores are maintained by a vascular epithelial growth factor, or VEGF, produced by the visceral epithelium. The endothelial cells synthesize nitric oxide, a vasodilator, and endothelin-1, a vasoconstrictor, that help regulate glomerular blood flow. The middle basement membrane is composed of a selective, permeable network of proteoglycans, the type 4 collagen, that's secreted and maintained by the epithelial cells. The visceral epithelium is composed of specialized cells called podocytes, from which pedicles, the foot projections, radiate and adhere to the basement membrane. The pedicels of the podocyte interlock with the pedicels of adjacent podocytes, forming an elaborate network of intercellular clefts, the filtration slits, or slit membranes, and modulate filtration. Nephrin, podocin, the CD2-associated protein, and other transcellular protein molecules ensure proper function of the filtration slits, and, when altered, cause glomerular disease. So here we're taking a look at that glomerular capillary. A scanning electron micrograph of normal glomerular capillary. Then section B here is a glomerular capillary wall. It shows the filtration membrane at, I guess, a 40,000 increase. The black arrow indicates direction of the urine flow. So, the space between the visceral and parietal epithelium is the Bowman space, or urine space, urinary space, which is continuous with the lumen of the renal tubules. The endothelium, the basement membrane, and the podocytes are covered with protein molecules bearing anionic or negatively charged that retard the filtration of anionic proteins and prevent proteinuria. The glomerular filtration membrane separates the blood of the glomerular capillaries from the fluid in Bowman space and allows all components of the blood to be filtered. With the exception of blood cells and plasma proteins with a molecular weight greater than 70,000, the glomerular filtrate passes through the three layers of the glomerular membrane and forms the primary urine. The glomerulus is supplied by the afferent arteriole and drained by the efferent arteriole, a group of specialized cells known as juxtaglomerular cells. The renin-releasing cells are located around the afferent arteriole, where it enters the glomerulus. Between the afferent and efferent arterioles is the macula densa, or sodium-sensing cells, of the distal convoluted tubule. Together, the juxtaglomerular cells and macula densa cells form the juxtaglomerular apparatus, the JGA. Control of renal blood flow, glomerular filtration, and renin secretion occurs at this site. The proximal convoluted tubule continues from the Bowman capsule and has an initial convoluted segment, the pars convoluta, and then a straight segment, the pars recta, that descends towards the medulla. The wall of the tubule consists of one layer of cuboidal epithelial cells, with a surface layer of microvilli, a brushboard, that increases reabsorptive surface area. This is the only surface inside the nephron where the cells are covered with microvilli. The proximal convoluted tubule joins the hairpin-shaped loop of Henle. The loop is composed of a thin descending segment, a thin ascending segment, and a thick ascending segment. The thin descending segment is composed of squamous cells, has no active transport function, and is highly permeable to water. The thin ascending segment is permeable to ions but not to water. But the thick ascending segment actively transports ions into the interstitium and passes urine into the distal convoluted tubule. Cortical nephrons are more numerous and have glomeruli originating close to the surface of the cortex or in the midcortex. The juxtamedullary nephrons have glomeruli located deep in the cortex, close to the medulla. The major structural difference between the two types of nephrons is the length of the loop of Henle. The cortical nephrons, the loop is short and may not extend into the medulla. The loop of Henle for the juxtamedullary nephrons, however, may extend the whole length of the medulla, approximately 40 millimeters. Juxtamedullary nephrons represent about 12% of the total number of nephrons and are important for the concentration and the dilution of urine. The distal tubule has straight and convoluted segments. It extends from the macula densa to the collecting duct, a large tubule that descends down the cortex and through the renal pyramids of the inner and outer medulla, draining urine into the minor calyx. The distal tubule is composed of two epithelial cell types, the principal cells that reabsorb sodium and water and secrete potassium, and the intercalated cells that secrete hydrogen and reabsorb potassium. That leads us to the blood vessels of the kidneys. The blood vessels of the kidneys closely parallel nephron structure. The major vessels are as follows. We've got our renal arteries that arise as the fifth branch of the abdominal aorta, dividing into the anterior and posterior branches of the renal hilum, and then subdivide into lobar arteries supplying blood to the lower, middle, and upper thirds of the kidneys. Then you've got your interlobar arteries. That subdivisions travel down the renal columns and between pyramids and form afferent glomerular arteries. Then you've got your arcuate arteries, consist of branches of interlobar arteries at the cortical medullary junction. They arc over the base of the pyramids and run parallel to the surface. Your glomerular capillaries consist of 4 to 8 vessels and are arranged in a fist-like structure. They arise from the afferent arterioles and empty into the efferent arterioles, which carries blood to the peritubular capillaries. They are a major resistance vessel for regulating intrarenal blood flow. The peritubular capillaries surround the convoluted portions of the proximal and distal tubules and the loop of Henle. They are adapted for the cortical and juxtamedullary nephrons. Your vasa recta is a network of capillaries that forms loops and closely follow the loop of Henle. It is the only blood supply to the medulla, which is important for the formation and concentration of urine. And then your renal veins. They follow the arterial path in reverse direction and have the same names as the corresponding arteries. They eventually empty into the inferior vena cava. The lymphatic vessels also tend to follow the distribution of the blood vessels. Urinary structures. So that brings us to ureters. The urine formed from the nephrons flows from the distal tubules and collecting ducts through the ducts of the Bellini and the renal papillae, the projections of the ducts, into the calyces, where it is collected in each renal pelvis, and then funneled into the ureters. Each adult ureter is approximately 30 centimeters long and is composed of long, intertwining smooth muscle bundles. The close approximation of smooth muscle cells permits the direct transmission of electrical stimulation from one cell to another. The lower ends of the ureters pass obliquely through the posterior aspect of the bladder wall. The resulting downward peristaltic activity propels urine into the bladder. Contraction of the bladder during micturition or urination compresses the lower end of the ureter, preventing reflux. Peristalsis is maintained even when the ureter is denervated, so ureters can be transplanted. Sensory innervation for the upper part of the ureter arises from the sympathetic inputs from the 10th thoracic nerve root, which with referred pain to the umbilical. The innervation of lower segments arise from the parasympathetic sacral nerves, with referred pain to the vulva or penis. The ureters have a rich blood supply. The upper part of the ureter is supplied by the renal arteries and the middle part by the common iliac arteries, and branches from the abdominal aorta and gonadal arteries, and the lower part mainly by branches from the internal iliac or vesical arteries. Your bladder and your urethra. The bladder is a bag composed of a basket weave of smooth muscle fibers that forms the detrusor muscle and its smooth lining of uroepithelium, the transitional epithelium. As the bladder fills with urine, it distends, and the layers of the uroepithelium within the lining slide past each other and become thinner as the volume of the bladder increases. The uroepithelium forms the interface between the urinary space and the underlying vasculature and connective nervous and muscle tissues. The uroepithelium also lines the urinary tract from the renal pelvis to the urethra. The uroepithelium maintains an important barrier function to prevent movement of water and solutes between the urine and the blood. It communicates information about luminal pressure and urine composition to surrounding nerve and muscle cells. The trigon is a smooth triangular area lying between the openings of the two ureters and the urethra. The position of the bladder varies by the age and sex. In infants and young children, the bladder rises above the symphysis pubis, providing easy access for percutaneous aspiration. In adults, it lies in the true pelvis, in front of the rectum and in front of the uterus in women. Inferiorly, the bladder sits on the prostate in men and on the anterior vagina in women. The bladder has a profuse blood supply, accounting for the bleeding that readily occurs with trauma, surgery, or inflammation. So here we're taking a look at the structure and location of the urinary bladder. The frontal view of a dissected urinary bladder male in a fully distended position. The urethra extends from the inferior side of the bladder to the outside of the bladder. A ring of smooth muscle forms the internal urethral sphincter at the junction of the urethra and bladder. The external urethral sphincter is composed of striated skeletal muscle and is under voluntary control. The entire urethra and bladder. The external urethral sphincter is composed of striated. Sorry, I lost my space. The entire urethra is lined with mucus-secreting glands. The female urethra is relatively short, only 3 to 4 centimeters. The male urethra is usually longer, anywhere between 18 to 20 centimeters, and has 3 main segments: prostatic, membranous, and penile. The prostatic urethra is closest to the bladder. It passes through the prostate gland and contains the opening of the ejaculatory ducts. The membranous urethra is the segment that passes through the floor of the pelvis. The penile segment forms the remainder of the tubule. The penile segment is surrounded by the corpus spongiosum erectile tissue and contains the opening of the bulbourethral gland. The innervation of the bladder and the internal urethral sphincter is supplied by parasympathetic fibers of the autonomic nervous system that arise from the sacral levels of the spinal cord, that S2 to S4, and contribute to bladder contraction and urine emptying. Sympathetic fibers originate from the T11 to L2 and inhibit the bladder body and excite the lower bladder and proximal urethral sphincter to retain urine. Sensory fibers from the bladder and urethra may extend as high as the T6 portion of the spinal cord. Somatic motor neurons in the pudendal nerve innervate in striated external urethral sphincter. The reflex arc required for micturition is stimulated by the mechanoreceptors that respond to stretching of tissue, sensing bladder fullness, and sending impulses to the sacral level of the spinal cord. When the bladder accumulates 250 to 300 milliliters of urine, the bladder contracts and the internal urethral sphincter relaxes through activation of the spinal reflex arc, known again as that micturition reflex. At this time, the person feels the urge to void. The reflex can be inhibited or facilitated by impulses coming from the brain, resulting in voluntary control of micturition. That leads us to renal blood flow. The kidneys are highly vascular organs and receive about 20 to 25% of the cardiac output, which in adults is about 1,000 to 1,200 ml of blood per minute. With a normal hematocrit of 45%, about 600 to 700 ml of blood flowing through the kidneys per minute is plasma. From the renal plasma, that RPF, 20%, approximately 120 to 140 ml per minute, is filtered at the glomerulus and passes into the Bowman capsule. The filtration of plasma per unit of time is known as the glomerular filtration rate, or GFR. which is directly related to the perfusion pressure in the glomerular capillaries. The remaining 80%, about 480 ml of plasma, flows through the efferent arterioles to the peritubular capillaries. The ratio of glomerular filtrate to RPF per minute is called the filtration fraction. Normally all but 1 to 2 ml per minute of the glomerular filtration is reabsorbed and returned to the circulation via the peritubular capillaries. The GFR is directly related to renal blood flow, or RBF, which is regulated by the intrinsic autoregulatory mechanism, neural regulation, and hormonal regulation. In general, blood flow to any organ is determined by the arteriovenous pressure difference across the vascular bed. If mean arterial pressure decreases or vascular resistance increases, RBF declines and urinary output decreases. Normal urinary output is about 30 ml per hour, the minimum in adults, or 0.5 to 1 ml per kilo per hour. Your autoregulation of the renal blood flow in the kidneys, a local mechanism, tends to keep the rate of glomerular perfusion and therefore the GFR fairly constant over a range of arterial pressure between 80 to 180 milligrams of mercury. Changes in afferent arterial pressure and resistance occurs in the same direction. Therefore, intrarenal blood flow and GFR are relatively constantly independent of renal perfusion pressure, a relationship maintained by an intrinsic autoregulatory myogenic mechanism of contraction when blood vessels are stretched. The purpose of autoregulation of intrarenal blood flow is to keep the RBF and GFR constant when there are increases or decreases in systemic blood pressure. Solute and water excretion and thus blood volume are regulated despite arterial pressure changes, and barotrauma is prevented in states of high systemic blood pressure. Here you're taking a look at the flow rate versus the arterial blood pressure. The autoregulation of the renal blood flow and glomerular filtration rate are stabilized with changes in mean arterial pressure between about 80 to 100 milligrams of mercury, or millimeters of mercury. So then you have your GFR rate, your renal blood flow. A second mechanism of autoregulation of RBF and GFR is the tubuloglomerular feedback. Because the glomerular filtration rate in an individual nephron increases or decreases in relation to changing arterial pressure, the macula densa cells of the juxtaglomerular apparatus and the distal tubule sense the increase or decrease amounts of filtered sodium. When the GFR and the sodium concentration decrease, the macula densa cells stimulate afferent arteriolar vasodilation and increase that GFR. At the same time, the juxtaglomerular cells secrete renin, which result in angiotensin II and release, causing vasoconstriction of the efferent arterioles, increasing glomerular hydrostatic pressure and GFR. The opposite occurs with an increase in GFR and sodium concentration at the macula densa. This mechanism prevents large fluctuations in body water and sodium. So here you take a look at the tubuloglomerular feedback system. If you have a decrease in arterial pressure, there's a decrease in the glomerular hydrostatic pressure, which means there's a decrease in GFR. The macula densa senses that decrease in sodium and the distal tubules, and thereby do two things. The juxtaglomerular cells increase renin, which increases angiotensin II, which is the efferent arterial vasoconstriction, so it increases the resistance, and the afferent arterial dilation decreases. Thus, we have an increase in the glomerular hydrostatic pressure and an increase in GFR. So, neural regulation of the renal blood flow. The blood vessels of the kidneys are innervated with sympathetic nervous fibers, located primarily on the afferent arterioles. When systemic arterial pressure decreases, increased renal sympathetic nerve activity is mediated reflexively through the carotid sinus and the baroreceptors of the aortic arch. The sympathetic nerves release catecholamines. This stimulates afferent renal arteriolar vasoconstriction and decreases RBF and GFR, increases renal tubular sodium and water reabsorption, and finally increases the blood pressure. A decreased afferent renal sympathetic nerves actively produces the opposite effects. The integrated response regulates water and sodium balance. Urinalase is a hormone released by the kidney and heart that promote the metabolism of the catecholamines, and in this way participate in blood pressure regulation. The sympathetic nervous system also participates in the hormonal angiotensin II regulation of the renal blood flow. There is no significant parasympathetic innervation. The innervation of the kidney arises primarily through the celiac ganglion and greater splanchnic nerve, leading us to hormones and other factors regulating renal blood flow. Hormones and other mediators can alter the resistance of the renal vasculature by stimulating vasodilation or vasoconstriction. A major hormonal regulator of renal blood flow is the renin-angiotensin-aldosterone system, that RAAS, which can increase systemic arterial pressure and change RBF. Renin is an enzyme formed and stored in granular cells of the afferent arterioles of the JGA. Renin release is triggered by a decrease in blood pressure in the afferent arterioles, decreased sodium chloride concentrations in the distal convoluted tubule, sympathetic nerve stimulation, and beta-adrenergic receptors on the juxtaglomerular cells, and release of prostaglandins. When renin is released, it cleaves an alpha-globulin, angiotensin, produced by the liver hepatocytes in the plasma to form angiotensin I, which is physiologically inactive in the presence of angiotensin-converting enzyme, that ACE enzyme, produced from the pulmonary and renal endothelium. Angiotensin I is converted to angiotensin II. Angiotensin II stimulates the secretion of aldosterone by the adrenal cortex, is a potent vasoconstrictor, and stimulates antidiuretic hormone secretion and thirst. Numerous physiologic effects of the RAS stabilize systemic blood pressure and preserve extracellular fluid volume during hypotension or hypovolemia. Actions include sodium reabsorption, potassium excretion, systemic vasoconstriction, sympathetic nerve stimulation, and thirst stimulation, which increases drinking. The effects of aldosterone combine with those of antidiuretic hormone in regulating blood volume. Natriuretic peptides are a group of peptide hormones, including atrial natriuretic peptide, or ANP, secreted from myocardial cells in the atria, and the brain natriuretic peptide, that BNP, secreted from the myocardial cells in the cardiac ventricles. They are natural antagonists to the renin-angiotensin-aldosterone system. When the heart dilates during the volume expansion or heart failure, ANP and BNP inhibit sodium and water absorption by kidney tubules, inhibiting the secretion of renin and aldosterone, vasodilate the efferent arterioles, and constrict the efferent arterioles. The result is increased urine formation, leading to decreased blood volume and a decreased blood pressure. The C-type natriuretic peptide is secreted from the vascular endothelium in the nephron and causes vasodilation. Urodilantin is a renal natriuretic peptide secreted by the distal convoluted tubules and collecting ducts and causes vasodilation, increases renal blood flow, and diuretic effect. Other hormones and mediators that influence renal blood flow are summarized here on this table. So here we got a couple different hormones. Adenosine, which is produced by the kidney, causes vasoconstriction of the efferent arterioles and decreases that RBF and GFR. Angiotensin II, produced systemically and within the kidneys, constrict afferent and efferent arterioles. So therefore, it decreases that RBF and GFR. The atrial and brain natriuretic peptides are produced by the atria and ventricles of the heart with hypertension and increased blood volume. They cause vasodilation of afferent arterioles and vasoconstrict of efferent arterioles. Modest increase in GFR with little change in the RBF. Bradykinin, produced in the kidneys from the kininogen, causes vasodilation by the release of nitric oxide and prostaglandins. It increases both RBF and GFR. Dopamine, produced by the proximal tubule, increases RBF, inhibits the renin secretion. Endothelin, produced by renal vessels, endothelial cells, mesenchymal cells, and distal tubule cells in response to bradykinin, angiotensin II, epinephrine, and stretch. Most active with renal disease, profound vasoconstriction of afferent and efferent arterioles, thereby decreasing RBF and GFR. Histamine, produced locally within the kidneys, modulates RBF in basal state and during inflammation, increases RBF by decreasing afferent and efferent arteriolar resistance, but therefore not decreasing GFR. Your nitric oxide, produced by renal vessel endothelial cells, with increased stretch and by stimulation of acetylcholine, histamine, bradykinin, ATP, increases vasodilation of afferent and efferent arterioles. Your prostaglandins 1 and 2, or PGI2 and PGE2, are produced locally within kidneys and decreased RBF. They dampen vasoconstriction caused by sympathetic nerves and angiotensin II. They prevent harmful vasoconstriction and renal ischemia. And then urodilantin, urodilatin, produced by distal tubules and collecting ducts. When there is an increased circulating volume and increased blood pressure, inhibits sodium and water reabsorption from medullary part of collecting duct, thereby producing diuresis. So, kidney function. The nephron can perform many functions simultaneously, as follows. First, it filters out plasma and glomerulus. It reabsorbs and secretes different substances along tubular structures. It forms a filtrate of protein-free fluid, so ultrafiltration, and regulates the filtrate to maintain body fluid volume, electrolyte composition, and pH within narrow limits. We're also going to take a quick peek here at this picture. The major functions of nephron segments: ADH, antidiuretic hormone. So if we're looking within the structure here, the glomerulus within the Bowman capsule, we have a proximal tube, the loop of Henle, the distal tube, and the collecting duct. It shows you that its primary function is reabsorption here for the proximal tubule. So it reabsorbs our sodium, glucose, potassium, amino acids, sodium bicarb, your PO4, your urea, your water, and the secretion of hydrogen and foreign substances. Its tonicity is relatively isotonic. However, within the loop of Henle, the concentrations of urine countercurrent mechanism, the descending loop, has water reabsorption and sodium diffuses in. In the ascending loop, your sodium is reabsorbed via an active transport and water stays in, and urea secretion in the thin segments. However, we can have an isotonic, hypertonic, or hypotonic solution there. Then in the distal tubule, we have the reabsorption of sodium, water, and bicarb, and the secretion of potassium, urea, hydrogen, your NH3, and some other drugs. And it's relatively a hypotonic solution there. And the collecting duct is the reabsorption of water. It also reabsorbs or secretes sodium, potassium, hydrogen, and NH3. Urea reabsorption in the medulla, the final concentration. So, quite interesting. Glomerular filtration is the movement of fluid and solutes across the glomerular capillary membrane into the Bowman space. Tubular reabsorption is the movement of fluids and solutes from the tubular lumen to the peritubular capillary plasma. Tubular secretion is the transfer of substances from the plasma of the peritubular capillary to the tubular lumen. The transport mechanisms are active as well as passive. Excretion is the elimination of a substance in the final urine. And then we're taking a look here at your filtration, reabsorption, and secretion. And that's, I guess, your pathway. So, urine formation, glomerular filtration, tubular reabsorption, and tubular secretion. The three processes by which the kidneys excrete urine. Water, electrolytes, glucose, and organic molecules are filtered at the glomerulus. Sodium and glucose are reabsorbed into the peritubular capillaries by active transport from the proximal convoluted tubules, and water reabsorption follows by osmosis. Sodium is reabsorbed by active transport from distal convoluted tubules. More sodium is conserved when aldosterone is secreted. Osmotic reabsorption of water from them occurs when antidiuretic hormone is present. Secretion of ammonia, your NH3, hydrogen, and potassium occurs from peritubular capillaries into distal tubules by active transport. So, glomerular filtration, the release or the fluid filtered by the glomerular capillary filtration membrane and released into the proximal convoluted tubule, is protein-free, but contains electrolytes, your sodium, chloride, and potassium, and organic molecules, creatinine in urine, and glucose, in the same concentration as found in plasma. Like other capillary membranes, the glomerulus is freely permeable to water and relatively impermeable to large colloids, such as plasma proteins. The molecule size and electrical charge are important factors, and the size of the filtration slits in the glomerular epithelium restricts the passage of proteins and other macromolecules. The negative charge along the filtration membrane further impedes the passage of negatively charged macromolecules because like forces repel each other. Positively charged macromolecules therefore permeate the membrane more readily than neutrally charged particles. Capillary pressure also affects glomerular filtration. The hydrostatic pressure within the capillary is the major force by moving water and solutes across the filtration membrane into the Bowman capsule. This pressure is determined by the systemic arterial pressure and the resistance to blood flow in the afferent and efferent arterioles. Two forces opposed to filtration effects of the glomerular capillary hydrostatic pressure, the hydrostatic pressure in Bowman space and the effective oncotic pressure of the glomerular capillary blood. Because the fluid in Bowman space normally contains only minute amounts of protein, it usually does not have an oncotic influence on the plasma of the glomerular capillary. And here we have a look at the glomerular filtration pressure. The afferent pressure, your Bowman space, and your efferent pressure. The combined effects of forces favoring and the forces opposing filtration determines the filtration pressure, the net filtration pressure. NFP is the sum of forces favoring and opposing filtration and is expressed by the following equation. Your NFP So, the estimated values contribute to the forces of net filtration are presented in this figure. As the protein-free fluid is filtered into Bowman capsule, the plasma oncotic pressure increases and the hydrostatic pressure decreases. The increase in glomerular capillary oncotic pressure is great enough to reduce the net filtration pressure to zero at the efferent end of the capillary and to stop the filtration process effectively. The low hydrostatic pressure and the increased oncotic pressure in the efferent arteriole then are transferred to the peritubular capillaries and facilitate reabsorption of fluid from the proximal convoluted tubules. Our filtration rate. The total volume of fluid filtered by the glomeruli averages about 180 liters per day, or approximately 120 ml per minute. A phenomenal amount of considering the size of the kidneys. Because only 1 to 2 liters of urine is excreted per day, 99% of the filtrate is reabsorbed into the peritubular capillaries, and thus is returned to the blood. The factors determining the GFR are directly related to the pressures that favor or oppose filtration. Obstruction to the outflow of urine caused by these strictures, stones, or tumors along the urinary tract can cause a retrograde increase in pressure at Bowman capsules and a decrease in GFR. Low levels of plasma protein in the blood from severe malnutrition or liver disease result in a decrease in the effective oncotic pressure of the glomerular capillary blood, which increases GFR. Excessive loss of protein-free fluid from vomiting, diarrhea, use of diuretics, or excessive sweating can increase glomerular capillary oncotic pressure and decrease the GFR. Renal disease also can cause changes in pressure relationships by altering capillary permeability at the surface area available for filtration. That tubular transport at the end of the proximal convoluted tubule, approximately that 60% to 70% of the filtered sodium and water and about 50% of urea have been reabsorbed along with 90% or more of potassium, glucose, bicarb, calcium, phosphate, amino acids, and uric acid. Chloride, water, and urea are reabsorbed passively, but are linked to the active transport of sodium, a co-transport mechanism. For some molecules, active transport in the renal tubules is limited as carrier molecules become saturated, a phenomenon known as a transport maximum. For example, when the carrier molecules for glucose reabsorption in the proximal convoluted tubule becomes saturated, the excess will be excreted in the urine. So, proximal convoluted tubule. An active reabsorption of sodium is the primary function of the proximal convoluted tubule. Water, most of the electrolytes, and organic substances are co-transported with sodium. The osmotic force generated by active sodium transport promotes the passive diffusion of water out of the tubular lumen and into the peritubular capillaries. Passive transport of water is further enhanced by the elevated oncotic pressure of the blood in the peritubular capillaries, which is created by the previous filtration of water at the glomerulus. The reabsorption of water leaves an increased concentration of urea within the tubular lumen, creating a gradient for its passive diffusion to the peritubular plasma. As the positively charged sodium ions leave the tubular lumen, negatively charged chloride ions passively follows to maintain electroneutrality. Because the inner membrane of the proximal tubular cells has a limited permeability to chloride, chloride reabsorption lags behind that of sodium. Hydrogen ions are actively exchanged for sodium ions in the tubular lumen. The hydrogen ions then combine with bicarbonate in the tubular lumen to form carbonic acid. Carbonic or bicarbonate is completely filtered at the glomerulus, and approximately 90% is reabsorbed in the proximal tubule. In the tubular lumen, hydrogen and bicarbonate ions combine to form carbonic acid, which rapidly breaks down or dissociates to carbon dioxide and water. CO2 and water then diffuse into the tubular cells, where carbonic anhydrase again catalyzes that CO2 and water to form HCO3 and an extra hydrogen atom. The extra hydrogen is secreted again, and bicarb combines with sodium and is transported to the peritubular capillary blood as sodium bicarb. Bicarbonate is thus conserved, and the hydrogen is reabsorbed as water. Therefore, these ions normally do not contribute to the urinary excretion of acid or the addition of acid to the blood. In addition, the proximal tubular secretion of hydrogen ions, secreted TMS, exists for creatinine and other organic bases, and endogenous and exogenous organic acids, including para amino hypurate or PAH and penicillin. These secretory mechanisms are important for eliminating drugs and other exogenous chemical products from the body, often after first conjugating them with sulfate and glucuronic acid in the liver. Many drugs and their metabolites are eliminated from the body in this way. When the renal tubules are damaged, metabolic byproducts and drugs may accumulate, causing toxic levels in the body. Normally, 99% of the glomerular filtrate is reabsorbed. When the GFR spontaneously decreases or increases, the renal tubules, and primarily the proximal tubules, automatically adjust their rate of reabsorption of sodium and water to balance the changes in GFR. Thus, a constant fraction of filtered sodium and water is reabsorbed from the proximal tubule. This prevents wide fluctuations in sodium and water excretion into the urine and maintains sodium and water balance, and is known as the glomerular tubular balance. GTB. GTB and tubular glomerular feedback together regulate sodium and water balance. Your overall loop of Henle. Urine can be hypotonic, isotonic, or hypertonic. Urine concentrations or dilutions occur principally in the loop of Henle, your distal tubules, and collecting ducts. The structural features of the medullary hairpin loops allows the kidney to concentrate urine and conserve water for the body. The transition of the filtrate into the final urine reflects the concentration or concentrating ability of the loops. Final adjustments in urine composition are made by the distal tubule and collecting duct according to the body's needs. Production of concentrated urine involves a countercurrent exchange system in which fluid flows in opposite direction through the parallel tubes of the loop of Henle. A concentration gradient in the medulla causes fluid to be exchanged across the parallel pathways. The concentration gradient increases from the cortex to the tip of the medulla. The longer the loop of Henle, the greater the extension into the concentration gradient. The loops multiply the concentration gradient, and the vasorectal blood vessels act as a countercurrent exchanger for maintaining the gradient. The process is initiated in the thick ascending limb of the loop of Henle, with the active transport of the chloride and sodium out of the tubular lumen and into the medullary interstitium. Because the lumen of the ascending limb is impermeable to water, water cannot follow the sodium chloride transport. This causes the ascending tubular fluid to become hypoosmotic and the medullary interstitium to become hyperosmotic. The descending limb of the loop, which receives fluid from the proximal tubule, is highly permeable to water, but it is the only place in the nephron that does not actively transport either sodium or chloride. Sodium and chloride may, however, diffuse into the descending tubule from the interstitium. The hyperosmotic medullary interstitium causes water to move out of the descending limb, and the remaining fluid in the descending tubule becomes increasingly concentrated, while it flows toward the tip of the medulla. While the tubular fluid rounds the loops and enters the ascending limb, sodium and chloride are removed and water is retained. The fluid then becomes more and more dilute as it encounters the distal tubule. The slow rate of blood flow and the hairpin structure of the vasorectal blood vessels allows blood to flow through the medullary tissue without disturbing the osmotic gradient. When blood flows into the descending limb of the vasorecta, it encounters the increasing osmotic concentration gradient of the medullary interstitium. Water moves out of the sodium and chloride diffuses into the descending vasorecta. The plasma becomes increasingly concentrated as it flows toward the tip of the medulla. As blood flows away from the tip of the medulla and toward the cortex, the surrounding interstitial fluid becomes comparatively more dilute. Water then moves back into the vasorecta, and sodium and chloride diffuse out and the plasma again becomes more dilute. The net result is a preservation of the medullary osmotic gradient. If blood were to flow rapidly through the vasorecta, as occurs in some renal disease, the medullary concentration gradient would be washed away and the ability to concentrate urine and conserve water would be lost. The efficiency of water conservation is related to the length of the loop of Henle. The longer the loops, the greater the ability to concentrate the urine. Urea is the major constituent of the urine, along with water. The glomerulus freely filters urea, and tubular reabsorption depends on urine flow rate. With less reabsorption at higher flow rates, approximately 50% of urea is excreted in the urine, and 50% is recycled within the kidneys. This recycled or recycling contributes to the osmotic gradient within the medulla and is necessary for the concentration and dilution of urine. Because urea is an end product of protein metabolism, individuals with protein deprivation cannot maximally concentrate their urine. Another function of the loop of Henle is the production of uromodulin, also known as the 10 horsefall protein, the most abundant protein in human urine. This protein is produced in the thick ascending loop and binds to uropathogens to prevent urinary tract infections, protects the uroepithelium from injury, protects against kidney stone formation, and is associated with the progression of kidney disease. The convoluted portion of the distal tubule is poorly permeable to water, but readily absorbs ions and contributes to the dilution of the tubular fluid. The later, straight segment of the distal tubule and the collecting ducts are permeable to water as controlled by antidiuretic hormone released from the posterior pituitary gland. Sodium is readily absorbed by the latter segment of the distal tubule and the collecting duct under the regulation of the hormone aldosterone. Potassium is actively secreted by the principal cells and reabsorbed in lesser amounts by intercalated cells in these segments. Potassium secretion is controlled by aldosterone and other factors related to the concentration of potassium in the body. Hydrogen also is secreted by the distal tubule and combines with non-bicarbonate buffers, uroammonium and urphosphate, for the elimination of excess acids in the urine. The distal tubule thus contributes to the regulation of acid-base balance by excreting hydrogen ions into the urine and by adding new bicarbonate to the plasma. The mechanism is similar to the conservation of bicarbonate by the proximal tubule, except that the hydrogen ion is excreted in the urine. The specific mechanism of acid-base balance and the acid excretion are described in Chapter 3. Urine is normally clear, yellow, or amber in color. Cloudiness may indicate the presence of bacteria, cells, or high solute concentrations. The pH ranges from 4.6 to 8.0, but it is normally acidic, providing protection against bacteria. Specific gravity ranges from 1.001 to 1.035. Normal urine does not contain glucose or blood cells and only occasionally contains traces of protein, usually associated with rigorous exercise. Your hormones and nephron function. Your antidiuretic hormone. The distal tubule in the cortex receives the hypoosmotic urine from the ascending limb of the loop of Henle. The concentration of the final urine is controlled by antidiuretic hormone, or ADH, which is secreted from the posterior pituitary, or neurohypophysis. ADH increases water permeability in the last segment of the distal tubule and along the entire length of the collecting ducts, which pass through the inner and outer zones of the medulla. The water diffuses into the ascending limb of the vasa recta and returns to the systemic circulation. The excreted urine can have a high osmotic concentration, up to 1400 MOSM. The volume is normally reduced to about 1% of the amount that was filtered at the glomerulus. An excess of ADH secretion is therefore one that can cause oliguria, or diminished excretion of urine. Clinically defined less than 400 ml per day or less than 30 ml per hour. The syndrome of inappropriate secretion of ADH, when the posterior pituitary hypersecretes ADH, resulting in excess water reabsorption and water excess in the plasma. Inadequate secretion of ADH results in diabetes insipidus and causes the distal tubules and collecting ducts to become impermeable to water. Water remains in the tubular lumen and is excreted as a dilute in large volume of urine. The mechanism for the regulation of ADH and plasma osmolarity again was described in Chapter 3 and 21. Your natriuretic peptides. Your natriuretic peptides that urodilantin, ANP, and BNP promote diuresis and were described under hormones and other factors regulating renal blood flow. Your diuretics as a factor in urine flow. A diuretic is an agent that enhances the flow of urine clinically. Diuretics interfere with the renal sodium reabsorption and reduce extracellular fluid volume. Diuretics are commonly used to treat hypertension and edema caused by heart failure, cirrhosis, and nephrotic syndrome. Diuretics are divided into 5 general categories: osmotic diuretics, carbonic anhydrase inhibitors, inhibitors of the urinary acidification, inhibitors of the loop sodium or chloride transport, your potassium sparing, your aldosterone receptor antagonist, and your aquaretics. The physiologic mechanism related to each category summarized here. So here we have a variety of different medications we could give. Your renal hormones. The kidneys activate or synthesize hormones that have systemic effect. These hormones include the active form of vitamin D, erythropoietin, renin-angiotensin-aldosterone, and natriuretic hormone. Vitamin D. Vitamin D is a hormone that can be obtained in the diet or synthesized by the action of ultraviolet radiation, your sun exposure, on cholesterol in the skin. These forms of vitamin D, your cholecalciferol, are inactive and require 2 hydroxylations to establish a metabolically active form. The first step occurs in the liver with hydroxylation at carbon 25, calcifidiol, and the second hydroxylation occurs at the first carbon position in the kidneys and is stimulated by the parathyroid hormone. The end product is 1,2,5-dihydroxycholecalciferol, or 1,2,5-dihydroxyvitamin D3. The active form of vitamin D. Calcitriol is necessary for the absorption of calcium and phosphate by the small intestine. A decreased plasma calcium stimulates the secretion of the parathyroid hormone. Parathyroid hormone then stimulates the sequence of events that helps restore plasma calcium level back to normal, including calcium mobilization from the bone, the synthesis of the 1,2,5-dihydroxyvitamin D3, your absorption of calcium from the intestine, increased renal calcium reabsorption, and a decreased renal phosphate reabsorption. Serum phosphate concentrations fluctuate also influence the renal hydroxylation of vitamin D. Decreased levels stimulate active 1,2,5-dihydroxyvitamin D formation, and increased levels inhibit formation. This results in compensatory changes in phosphate absorption from bone and the intestine. Individuals with renal disease have a deficiency of 1,2,5-dihydroxyvitamin D3 and manifest symptoms of disturbed calcium and phosphate balance. Erythropoietin is produced by the fetal liver and the adult kidney and is essential for normal erythropoiesis. With decreased oxygen delivery in the kidneys, oxygen-sensing peritubular fibroblasts in the juxtamedullary cortex release erythropoietin, which stimulates the bone marrow to increase the rate of red blood cell production. Individuals with chronic renal failure develop anemia related to reduced erythropoietin secretion. Erythropoietin also affects the endothelium and promotes angiogenesis, mitogenesis, and anti-apoptosis. It is also anti-inflammatory, cytoprotective, and neurotrophic. So tests of the renal function, your renal clearance. A number of specific renal functions can be measured by renal clearance. Renal clearance techniques determine how much of a substance can be cleared from the blood by the kidneys per given unit of time. The application of this principle permits an indirect measure of GFR, tubular secretion, tubular reabsorption, and renal blood flow. Clearance and glomerular filtration rate. The GFR provides the best estimate of functioning renal tissue. Damage to the glomerular membrane or loss of nephrons leads to a corresponding decrease in GFR. The measurement of GFR requires use of the substance that has a stable plasma concentration, is not protein-bound, is freely filtered at the glomerulus, does not influence GFR, and is not secreted, reabsorbed, or metabolized by the tubules and is easy to measure. Inulin, a fructose polysaccharide, is one substance that meets the criteria for measurements of GFR. The kidney clears inulin from the plasma by filtering it at the glomerulus, reabsorbing nearly all of the fluid, and excreting the inulin left behind in the urine. The amount of inulin filtered is equal to the volume of plasma filtered, your GFR, multiplied by the plasma concentration of inulin. The amount of inulin in the urine is equal to the volume of urine per unit of time, UV, usually 24 hours, multiplied by the inulin concentration of urine, because all the inulin filtered is excreted in the urine. So you have your GFR times your concentration of inulin, which also equals your inulin concentration of urine times time. Your GFR can be calculated by rearranging the formula. So your GFR, your milliliters per minute, can equal your concentration of inulin times time divided by the, it is your concentration of urine times time divided by the concentration of inulin. The accurate determination of insulin clearance requires constant infusion to maintain a stable plasma level. This is time-consuming, inconvenient, and prone to error. Therefore, the clearance of creatinine, a natural substance produced by muscle and released into the blood at a relatively constant rate, is commonly used as an estimate clinically. It is freely filtered at the glomerulus and is not reabsorbed by the renal tubules, but a small amount is secreted by the renal tubules. Therefore, creatinine clearance overestimates the GFR, but within tolerable limits. Creatinine clearance provides a good estimate of GFR because only one blood sample is required in addition to a 24-hour volume of urine. The GFR estimated by creatinine clearance is calculated as follows. Your GFR, your ml per minute, is your urine, times time over your P. This one's not broken down as nicely. Here it is. So your cystatin C is a clear protein in serum filtered at the glomerulus and metabolized in the tubules. Serum levels of cystatin C also are a marker for estimating GFR, particularly for mild to moderate impaired renal function. A combined creatinine and cystatin C estimate of GFR was developed in 2012 and considers age, race, and gender. Formulas are used to estimate GFR. The Cockcroft and Galt creatinine-based formula is commonly used and considers age, body weight, and plasma creatinine values. And the National Kidney Foundation recommends the modification of diet and renal disease. Your MDRD equation, the chronic kidney disease epidemiology collaboration equation, has been developed as a more precise estimate of GFR than the MDRD and considers age, gender, and race. In 2012, cystatin C and combined creatinine and cystatin C equations were developed. Calculators for the estimates of GFR using these formulas are readily available on the internet, and your normal values are anywhere between 90 to 120 ml per minute. Your plasma creatinine concentration. A chronic decline in GFR over weeks or months is reflected in the plasma creatinine concentration. The plasma creatinine concentration has a stable value, and the GFR is stable because creatinine has a constant rate of production as a product of muscle metabolism. The amount filtered is approximately equal to the amount excreted. When the GFR declines, the plasma creatinine concentration increases proportionately. Thus, the GFR and your plasma creatinine concentration are inversely related. If the GFR were to decrease by 50%, the filtration and excretion of creatinine would be reduced by 50%, and creatinine would accumulate in plasma to twice the normal value. Therefore, elevated plasma creatinine concentration values represent decreasing GFR. In the new steady state, however, the total amount of creatinine excreted in the urine would remain the same because the proportionate decrease in GFR and increase in plasma creatinine concentration. The application of this principle is simple and useful for monitoring progressive changes in renal function. The test is most valuable for monitoring the progress of chronic rather than acute renal disease because it takes 7 to 10 days for the plasma creatinine level to stabilize when GFR declines. Serial measures can be obtained over a long time and plotted as a curve of glomerular function. Your normal PCR value decreases with advanced age, since older adults experience a decrease in lean muscle mass. The PCR value becomes evaluated or elevated during trauma or breakdown of muscle tissue. In such instances, the value is then not useful for estimating GFR. Your blood urea nitrogen, or BUN. The concentration of urea nitrogen in the blood reflects glomerular filtration and urine concentration capacity. Because urea is filtered at the glomerulus, your BUN levels increase as glomerular filtration drops. Because urea is reabsorbed by the blood through the permeable tubules, the BUN values rises in the states of dehydration and acute and chronic renal failure, when passage of fluid through the tubules is slowed. BUN values also varies as a result of altered protein intake and protein catabolism, and therefore is a poor measure of GFR. The normal range for BUN values in an adult is 10 to 20 milligrams per deciliter of blood. Your clearance and renal blood flow. The clearance formula also can be used to estimate renal plasma flow, your RPF and RBF, using the molecules called the para-aminohydroxyuric acid. Some PAH is filtered at the glomerulus, and most of the remainder is secreted into the tubules in one circulation through the kidneys. If all of the PAH were removed from the plasma during a single pass through the kidney, total RPF could be determined. Because the supporting and non-secreting structures of the kidneys receive 10% to 15% of the effective renal blood flow, clearance of pH measures only what is known as the effective renal plasma flow, which is 85 to 90% of the true renal plasma flow. And there's equations to that, where UPA is the concentration of pH in urine and PPAH equals the concentration of pH in plasma. The estimation of the ERBF can then be calculated by considering the hematocrit in the following formula. Your ERBF equals your ERPF, or 1 minus hematocrit. Evaluation of the biochemical components of the blood and urine provides valuable information regarding renal function. Your urinalysis. Your urinalysis is a non-invasive and relatively inexpensive diagnostic procedure. The best results are obtained from fresh, cleanly voided specimens because decay permits changes in the composition of urine. Urinalysis includes evaluation of color, turbidity, protein, pH, specific gravity, sediment, and supernatant. Urine color is normally a clear, light yellow because of urochrome and other pigments. When formed substances, crystals, blood cells, or casts are in the urine, it appears turbid. Protein in the urine creates marked foaming when shaken, and the foam is yellow or orange when the urine contains bile pigments. Urine does not normally contain protein or bile. Your urine pH normally ranges between 5 and 6.5, but it may vary from 4.5 to 8. Urine is more alkaline after eating and then becomes less alkaline before the next meal. Because sleep is accompanied by intermittent hypoventilation, urine is more acidic on awakening. Specific gravity is an estimated measure of the solid concentration of the urine. The specific gravity of any solution is measured by comparing the weight of the solution with an equal volume of distilled water. Hence, specific gravity is not a true measure of the number of concentration of particles, but it correlates well with osmolality and is a useful clinical tool. Specific gravity usually is measured with a hydrometer in a cylinder of urine. The normal value is 1.016 to 1.022. Dipstick evaluations may be falsely high when urine pH is less than 6 and falsely low when the pH is more than 7. The final urine osmolality is primarily to function of ADH, which controls water reabsorption in the collecting ducts. If the kidney is unable to concentrate or dilute urine, given a stimulus, the cause is usually a malfunction of the renal tubules or inappropriate ADH secretion by the posterior pituitary gland. The state of hydration also affects the urine's specific gravity, so hydration status should be evaluated before making a diagnosis. This determination is helpful for differentiating oliguria caused by intrinsic renal disease from hypovolemia as a result of dehydration. Urine sediment. The urine sediment is examined microscopically and may contain cells, casts, crystals, and bacteria. Epithelial cells may be seen in the microscopic field because they are shed naturally through the urinary tract. Your red blood cells, your normal urine contains few to no red blood cells. If a large number of red blood cells are present, this is known as hematuria, and the sediment may be red or brown. An alkaline or hypotonic urine causes lysis of red cells. However, this so that the cells will not be seen. Urine then will be positive for hemoglobin, and the specific gravity will be elevated. Hematuria can occur with the administration of anticoagulants and with several renal diseases. Your casts. Casts, or accumulations of cellular precipitates, originate in the renal tubules, from which they take their shape. They are cylindrical with distinct borders. All casts are a precipitated microprotein matrix and arise primarily from the ascending limb of the distal tubule. Red cells cast indicate bleeding into the tubules or escape of red blood cells through the glomerulus. White cell casts are associated with an inflammatory process. Epithelial cell casts indicate degeneration of tubular lumen or necrosis of renal tubules. The type of cast identified suggests the disease process occurring in the kidneys. Leading us to crystals. Crystals. Numerous kinds of crystals can be observed in the urine. They may be composed of cysteine, uric acid, calcium oxalate, or phosphate. They may not be initially observable, but as urine cools, crystals will form. Crystals tend to form in a concentrated acidic or alkaline urine. Generally, they are not clinically significant. Crystal formation is diagnostically insignificant, usually indicating inflammation, infection, or a metabolic disorder. You have white blood cells. White blood cells in the urine is a condition called pyuria and are indicative of urinary tract infections, particularly when bacteria are present. Glomerulonephritis and nephrotic syndrome also may demonstrate pyuria, but usually in combination with proteinuria, red cells, and casts. The finding of white blood cells casts reflects a kidney infection because the casts are not formed in the bladder or prostate. If white blood cells are present in the urine, a culture should be done for specific identification of bacteria and sensitivity of bacteria to antibiotics. Other measures, your dipstick and reagent strips, are available for detecting other substances in the urine, including glucose, bilirubin, urobilinogen, leukocyte esterase, and nitrates, ketones, proteins, hemoglobin, and myoglobin. Aging and the renal function. This is our last section here. Throughout life, the kidney responds to an increased workload by compensatory hypertrophy. This hypertrophy is marked in individuals who have donated a kidney for transplant or have lost functioning nephrons from trauma or disease. The glomeruli increase in diameter, and the tubules enlarge, effectively to maintain the regular function of the kidney. Hypertrophy occurs more rapidly and with a larger size increase in younger individuals and in those with high protein intake. Changes in the kidneys occur throughout life, resulting in a reduction in size and linear decrease in renal blood flow and GFR. However, it is less pronounced in healthy individuals. Reference values for estimated GFR are available by age group. The number and size of nephrons decrease with aging, possibly related to oxidative stress, inflammation, and associated clinical conditions, your hypertension and diabetes mellitus. The primary mechanism appears to be the change in the renal vasculature and perfusion patterns related to atherosclerosis that leads to a reduction in number of nephrons and nephrosclerosis. Tubular atrophy also occurs. The rate of nephron loss accelerates after 50 years of age. By about 75 years of age, the nephron population is reduced by 30% to 50%, with loss of renal mass occurring primarily at the cortex. Degenerative changes with the nephrons also occurs with aging. The glomerular capillaries become sclerotic, and remaining glomeruli become hypertrophic. The glomeruli may disappear completely. The arcuate and interlobular arteries become tortuous, contributing to ischemia. The loss of glomerular tuft may cause a shunt between the afferent and efferent arterioles. Although loss of juxtaglomerular nephrons still allows the vasa recta to be perfused, the combination of events contributes to a reduced ability to excrete a concentrated urine. Thus, the specific gravity of the urine in older individuals tends to be on the low side of normal. Tubular transport changes with aging, although under normal conditions the tubules function adequately. Adaptations to stress conditions is more difficult. Glucose, bicarb, and sodium are not efficiently reabsorbed, and hyperkalemia is more common because the decreased secretion response to acid or base loads is delayed and prolonged. Sudden or large changes in pH or fluid load may lead to serious imbalances with increased risk of hypervolemia or hypovolemia. Acute losses or chronic fluid deficits can lead to renal insufficiency in the older adult. Administration of drugs eliminated by renal processes may require dose modification and more astute observation for toxic side effects. Contrast agents and non-steroidal anti-inflammatory drugs should be used with caution. The TM for glucose reabsorption decreases with age, contributing to greater amounts of glucose in the urine. This is an important consideration when glycosuria or glycosuria is used for screening or monitoring the process of diabetes in older adults. These changes occur independently of disease, however, indicating a normal process of aging. An age-related decline in renal activation of vitamin D decreases intestinal absorption of calcium and older adults need more vitamin D to overcome diminishing renal function. Previous or concurrent renal disease or urinary tract obstruction may amplify age-related changes in function. Bladder symptoms are common among older adults and include frequency, urgency, and nocturia. Ischemic-induced neurogenic and myogenic changes in bladder structure and function may contribute to some symptoms as well as influence outside the urinary tract. Your cardiovascular disease, prostatic disease, uterine prolapse, stool impaction, and hormonal changes. Changes in neurotransmission influence the micturition reflex and may lead to an overactive or underactive bladder. This concludes our chapter here on the structure and function of renal and urological systems. We'll jump into chapter 39 pretty quickly here, and we'll continue right along. So we'll see you at that point.